Good evening. We will now discuss the respiratory care of neurocritical care patients. Respiratory care in these patients is slightly different from the patients in the general ICU. They often require respiratory support for non-respiratory causes. Often they have normal lungs. Issues like altered sensorium, inability to cough or preserve their airway could be real issues. Non-invasive methods of support like HFNO and NIV are often contraindicated in this population. Not just that, respiratory adjustments that make changes in carbon dioxide levels or titration of PEEP can affect the cerebral blood flow, and this can change the trajectory of the disease. Most patients with acute insult to brain have very high level of asynchronies. They have high respiratory drives and flow starvation, ineffective triggers, and failed triggers are very common. And on the other end of the spectrum, the brain dead patients have this peculiar asynchronic called reverse trigger. Even if you manage to ventilate these patients successfully, weaning them off ventilation poses several challenges because a normal standard of care in general ICU, like daily interruption of sedation, spontaneous breathing trials, early mobilization, extubation to NIV, these are not possible in this population. In this talk, I'll deal with acute brain injury, the post-cardiac arrest ROSC patients, and acute peripheral nerve and neuromuscular junction disorders. I will not deal with the acute admissions of neurodegenerative patients who sometimes come to the ICU. Acute brain injury will encompass traumatic brain injury, acute ischemic stroke, subarachnoid hemorrhage, intracerebral hemorrhage, and sometimes issues like acute encephalitis. Acute brain injury is peculiar in the sense that even when it happens to patients with normal lungs, this by itself can produce respiratory distress because of what is called a neurogenic pulmonary edema. The intense catecholamine release can produce sudden elevation in the SPR and PVR, along with something like a Takotsubo cardiomyopathy, and can produce a neurogenic pulmonary edema. The inflammatory mediators released may also contribute to ARDS. This is in addition to the added risk of aspiration. Not just that, in the same way that brain injury can produce injury to the lung injury can also affect the trajectory of brain injury and its recovery. Hypoxia, hypocarbia, mechanical ventilation and ventilation-induced lung injury producing inflammatory mediators, asynchronies, all those can affect recovery from brain injury. So in this particular talk, I'll be basing most of it on this consensus recommendation of the ISCCM on mechanical ventilation in patients with acute brain injury. The first question that they have considered is the issue about indications for endotracheal intubation. So this should be taking into account level of consciousness, presence of agitation or combativeness, loss of airway protective reflexes, significant ICP elevation, etc. So GCS in acute brain injury is a good indicator for the need for intubation. GCS less than 8, especially in traumatic brain injury, should be intubated if their GCS falls less than 8. Protective reflexes are important. And when you talk about protective reflexes, we are talking about the presence of cough reflex and swallowing reflex. The gag is not so good at predicting the ability to maintain their airway, even though it is the one that we commonly check and it's easy to assess. In patients who have significant ICP elevation, they need to be intubated. And of course, if they are having impending herniation, they need to be intubated on our back. And if there are non-neurological indications for intubation, like cardiopulmonary indications, they need to be intubated. Agitation and combativeness If you can manage it without intubation, well and good. But if you need to sedate them and you're going to reduce a GCS further, then probably you need to consider intubation as well. How about non-invasive respiratory support? No recommendations are given for an IV in this population. And for HFNO, they give a conditional recommendation based on no evidence. That is, those patients who are not to be intubated, but who needs more oxygen, it may be tried. Intubation in these patients is not so simple. We need to follow the emergency neurological life support algorithm. You can freely download from the Neurocritical Care Society webpage. I'm sure you cannot read this, and that was not my intention. What I need you to focus is this. Pay attention to three things. Cervical spine stabilization. If ICP elevation is a concern, you keep the head of the bed elevated to 30 degrees and make them flat only when you're starting to do laryngoscopy. And as soon as the tube is in and secured, you raise the bed back to 30 degrees. You use lidocaine as pre-medication before laryngoscopy and can use rapid sequence induction, which may be modified to use ketamine as an induction agent if your ICP is actually elevated and you need to avoid hypoxia and hypotension at any cost. Consider fluid loading these patients before induction and consider having an arterial line before intubation and having a pressor ready in case they have hypotension. Having intubated them, you need to pay attention to the mechanical ventilation settings. So if they have lung injury, we need to give them lung protective ventilation, which has very good evidence. But the issue with lung protective ventilation is that permissive hypercapnia, which we allow in other patients, is not something which we can have in traumatic brain injury because it will lead to raised ICP. So if there is no significant ICP elevation, you can use lung protective ventilation. Otherwise, when you use lung protective ventilation, you need to be having some measure of monitoring the ICP to see that the ICP is not actually getting elevated. In patients who have a raised ICP, they could not make any recommendation because the evidence was not very high. But hypoxia can be harmful and should be avoided. What levels of pH, PaO2, and PCO2 are to be maintained? So PaO2 between 80 to 120 is recommended. Hypoxia can be harmful. We now have evidence that hyperoxia can also be harmful. The optimal carbon dioxide is between 35 to 45. Transient hyperventilation when you have signs of herniation can be done based on no evidence, but otherwise hyperventilation should be avoided. This is the mantle bundle, which is now the recommendation for patients who have traumatic brain injury to avoid cerebral hypoxia. So you pay attention to all the letters in the mantle, temperature, hemoglobin, electrolytes, but focus on lung protective ventilation. So you provide lung protective ventilation at tidal volumes of 6 to 10 ml per kilogram of predicted body weight. A lowest respiratory rate to achieve a carbon dioxide of 35 to 45. A plateau of less than 24, a driving pressure less than 13, and a mechanical power less than 17 joules. So this is the recommendation for lung protective ventilation. Sometimes these patients still have hypoxia. If that is really there, then what about use of rescue intervention? Neuromuscular blockade is recommended. It's a strong recommendation for a short period of time, can be done. ECMO, no recommendations are made, but they say that the evidence overall is in favor of ECMO. No recommendations or no evidence for echo. How about recruitment manuals? Recommendations are not made again, but if they are hypoxic, they say the evidence is somewhat in favor of recommendation because hypoxia can be harmful. Prone positioning, very low evidence in favor of prone positioning if the ICP is not high, if these patients have ARDS. If ICP is high, there is no recommendation. How about weaning these patients? So there are some challenges to weaning these patients because you cannot do your daily interruption of sedation and spontaneous breathing trials in these patients because they might have high ICP. Neurological response may be impaired and difficulty in assessing their level of sensorium can be a challenge. Weak cough, presence of secretions, and swallowing disorders are very common. And after extubation, NIV in case there is a failure is often contraindicated. So these are real challenges in extubating these patients, and extubation failure is quite common. And the commonest cause for extubation failure in these patients is neurological impairment. When I say it is neurological impairment, it is not exactly GCS. In this paper published in ATS and in other papers, when they look at GCS as a predictor of extubation success, it is not a strong predictor. Both the total GCS as well as the motor component of GCS was not significantly correlated with the success of extubation, whereas what was much more predictive was the absence of a cough reflex. Positive fluid balance, age, male sex were also associated with good success. So the recommendation is to decide on extubation, several factors, including the trajectory of the disease, the level of consciousness, the presence of protective airway reflexes need to be considered, the same as intubation. Neurological status should be accounted for. The trajectory should be accounted for. Level of consciousness in GCS as such is not a strong predictor, and you need to look at airway protective reflexes in the presence of cough and swallowing. And they don't provide a GCS cutoff in their recommendation when you decide on extubating these patients. The ENEO study on extubation found 7 main predictors of extubation success. The original insult being TBI, presence of vigorous cough, swallowing reflex, need for ET suction less than twice a year in an hour, GCS more than 6, and absence of temperature, fever. There are some scores which are well validated. In the traumatic brain injury, the best validated score is the Visage score, which looks at visual pursuit, the swallowing attempts, Glasgow-Coma scale, and age. There is a set score which has been validated for acute ischemic stroke, and for intracranial hemorrhage, there is this interesting score called the TRUC score. It's interesting because in addition to the GCS component, they have incorporated a radiological component. So the location of the bleed, if there is a thalamic hemorrhage, or 2 other factors, a presence of hydrocephalus or presence of midline shift. If these are there, the chance that this patient could be extubated is very low. So a combined score is considered when to decide on extubation in these patients. Coming to tracheostomy timing, early versus late tracheostomy in these patients has been a raging controversy since time immemorial. The recommendation is that tracheostomy should be considered in a patient who has failed 1 or more trials of extubation, and if patients have a persisting impaired consciousness. The real timing of tracheostomy, no recommendations are made because the evidence is contradictory. And no good high-quality RCTs show a consistent benefit for early tracheostomy in mortality. Having said that, we have various non-RCT observational trials which show a benefit with early tracheostomy, which show reduced VAP, reduced length of stay, and reduced duration of mechanical ventilation with tracheostomy. The Center TBI trial actually looked at quite a large number, 1,358 patients, and found that 31% needed a tracheostomy. This is in a population with traumatic brain injury. And there was considerable heterogeneity. The rate of tracheostomy varying from 7.9 to 50, even though the mean was around 31. And the median timing was around 9 days. They also found that a late tracheostomy patient was likely to have a composite worse neurological outcome, which is a composite of mortality and poor neurological scores. So overall in favor of early tracheostomy, how early we need to actually personalize. So in short, in acute brain injury, you intubate the patients based on their trajectory of disease, the severe presence of ICP, and the need for ventilation. I would like to highlight some changes between the two major representatives here, the TBI and subarachnoid hemorrhage. The priorities of neurocritical care, even though in both we are trying to provide the same goals, are slightly different. In a traumatic brain injury patient, for example, we would be looking at the ICP and trying to maintain a CPP, and hemodynamic targets are usually maintaining CPP, keeping them deeply sedated initially until their brain injury is healing, and you would try and reassess them a little later once their ICP is coming under control. Whereas for subarachnoid hemorrhage, initially your priority is actually to have the BP on the lower side to prevent a rebleeding. And even after the aneurysm is sequered, the target in them, hemodynamic target in them, is not a raised BP, because in these patients, we are more concerned about delayed ischemic deficits, and to actually pick that up early, we actually tend to keep them on minimal sedation so that sensorium can be assessed. And the standard of care in this patient is to have a ventricular drain, and ICP because of that is not a major issue as in TBI patients. How about cardiac arrest patients? Ventilatory settings, we have data from a lot of trials which shows that which gives us a lot of information regarding the ideal settings of mechanical ventilation. What's most important is that hyperoxia as well as hypoxia can be harmful. So this is mortality with the distribution of oxygenation. On this side, you have hypoxia and the mortality is high. For normoxia, the mortality and outcome is better. But as hyperoxia happens, the actually outcome also worsens. So we have a sweet spot somewhere between 80 to 120 PO2s. So this is a paper which tells you the 10 rules for optimizing ventilatory settings. So low tidal volume, plateaus less than 20 if possible, PEEP at least 5, with a driving pressure of less than 13, respiratory rate, the lowest to maintain a PCO2, try to have a rate around 8 to 16, mechanical pressure less than 17 joules, PO2s, PCO2s, we have already said, and avoid hypothermia, and the BP has to be individualized. Coming to the last session of this talk, neuromuscular disorders and neuromuscular junction disorder, peripheral nerve and neuromuscular junction disorders, mainly myasthenia gravis and Guillain-Barré syndrome. So in addition to your subjective levels of neuromuscular or respiratory failure, you have objective measures like a vital capacity less than 20 ml per kg, the maximum inspiratory pressure less than -30, and maximum expiratory pressure less than 40. These are things that you need to watch out for. And if these go down, these are some indications to electively intubate. Patient becoming drowsy, hypoxemic, or hypercalbic, it's actually too late. And if that happens, you need to urgently intubate these patients. There is this EGRI score, the Erasmus GBS respiratory insufficiency score, which has been validated as a predictor for need for mechanical ventilation in patients who come with Guillain-Barré syndrome. And for weaning these patients, in addition to the normal weaning parameters, you again look at improvement in forced vital capacity, at least more than 10 ml, and a NIF and maximal expiratory pressure normalizing. Thank you.